We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for the treatment of genital herpes, gonorrhea, chlamydia, and syphilis. Now let's explain the pathophysiology and clinical presentation of genital herpes, gonorrhea, chlamydia, and syphilis. Let's take a look at herpes simplex virus. Now, when the virus enters the body through the skin or mucous membrane, and that could be genital area, or it could be essentially anywhere where you have a mucous membrane. So, you can think of the oral cavity. Once the virus enters, it will essentially go into the nervous system, and then it will have, initially some, symptoms that will be essentially on the skin. But once it goes to the nerve, it will have a period of latency. So it could be, many years that the virus will be inactive, and then it will never really leave the body. So there will be episodes of recurrence. So every time there is a reactivation of this latent virus, there are two possibilities. One possibility, which we call recurrence, is that you will have symptomatic manifestations. So there will be, for example, blisters on the skin, and this will be a contagious phase of the infection because there will be new viruses replicating inside the lesion, and this can be transmitted to other people by touch. And the other possibility is asymptomatic viral shedding, and this is essentially once the virus is reactivated, it goes to the surface of the skin. It's asymptomatic in the sense that it will not cause symptomatic manifestation, so there will not necessarily be a lesion on the skin, but because the virus is actively replicating, it will be able to shed new viruses, and this is also contagious. And this causes a problem because, well, it's easy to avoid transmission when there is an active lesion going on. People are, unaware of asymptomatic viral shedding, which is that they could, there's not much they can do to prevent this transmission when they have asymptomatic viral shedding. Now, of course, the virus can infect the orofacial area, so, anywhere around the mouth and, inside the mouth. And this orofacial herpes is more common with HSV1. So between HSV and 2, more likely to have HSV1 cause this type of infection. And again, regardless of whether it's HSV1 or 2, the course is essentially the same. There will be a period of latency followed by sporadic reactivations. Now, it can also lead to genital HSV infection, and this could be both men and women. And when it comes to genital HSV, it is more common to have recurrences with HSV2. But again, either HSV1 or 2 can cause genital herpes. It's just that it's more likely to have recurrences with HSV2. HSV1 just doesn't recur that often in the genital area. Now, another thing to note about this virus is that although someone may have genital HSV infection, it may not necessarily be limited to that region. So even if the route of transmission was sexual transmission, extragenital lesions may occur during the course of primary genital infection. So extra means outside of genital lesions. Now, another possibility is eye infections, so ocular infections with HSV. They're not as common, but they can occur, and they can be pretty much serious. And lastly, encephalitis can occur from HSV. So this is essentially infection in the CNS system, and that's something that also can happen with HSV. Now let's take a look at some of the manifestations of genital HSV infection specifically. So one thing to note is that the incubation period is about 1 week, so 4 to 7 days. So essentially once somebody is exposed, it will take about a week for symptoms to develop. And for the initial infection is essentially lesions that appear at the site of transmission, so typically the genitals or the adjacent skin. For the initial infection, it's usually the lesions are bilateral, so there is some symmetry, and essentially the lesions progress from erythema to papules to vesicles to ulcers that ultimately develop a crust. And without treatment, this essentially resolves over 2 to 3 weeks. And half of the patients report other systemic symptoms, so such as headache, fever, malaise, dysuria, or lymphadenopathy. After a period of latency, there will be recurrent genital disease, so essentially reactivation, which result either in symptomatic or asymptomatic viral shedding. Symptomatic recurrence may be preceded by localized prodromal symptoms. So sometimes people can tell if a recurrence is coming up. They can sense itching or tingling. So prodromal, essentially, if you look at this picture over here, the first phase of the infection is incubation period. Then the second phase is prodromal period. That's before the symptoms actually become visible. So prodromal is that just before the symptoms come up. And that's significant because if somebody anticipates that symptoms are coming up, they may choose to proactively start treatment and at the same time prevent transmission by practicing caution. As I mentioned, recurrence is less frequent with HSV1 compared to HSV2. So keep that in mind when we decide, when we decide treatment for these. And, they typically, the recurrences resolve within 5 to 10 days. Now, chlamydia and gonorrhea manifestations are pretty similar. So for chlamydia, it could be asymptomatic infection among both men and women. And in general, you can think of, urogenital as site of infection. So this will be pain or burning during urination, discharge from the vagina or penis, and pain or swelling in the testes. The second, and these are, depending on the route of sexual intercourse is where you would get these different manifestations. So for the rectal and anal, you will have rectal bleeding or anal discharge, painful bowel movement. And then outside of your genital and rectal, you can have conjunctivitis. And in severe cases, you can have joint pain and swollen lymph nodes. Now, when we look at gonorrhea, again, asymptomatic infection is common among women until complications occur. For men are more likely to be symptomatic, so it doesn't list men here. Gonorrhea very symptomatic in men, and again the same routes, right? So urogenital, again similar, symptoms for each route. So rectal and anal, and then one thing that's a little different between gonorrhea and chlamydia is that chlamydia, when for example, if you consider the oral route of transmission, chlamydia is less likely to cause sore throat, whereas gonorrhea is more likely to cause sore throat. So sore throat is pharyngitis, I should say, is more of a possibility for gonorrhea. And then of course conjunctivitis, and gonorrhea can be pretty severe when it gets to disseminated gonococcal infection. And then lastly, we will go over syphilis, so manifestation of syphilis. So it's important to think of syphilis at different phases. So we have primary syphilis, secondary, and tertiary. Primary syphilis essentially is, when someone has just been exposed, and, typically 3 weeks later, they're going to have the very first symptom, which is at the site of transmission. So typically a single ulcer, or sometimes it might be multiple lesions, typically on the genitals area. That essentially marks primary syphilis. Now, sometimes these are missed because although there will be lesions, these are painless. So if somebody doesn't notice it because there is no pain, it's possible for them to miss this. Now, when we get to, assuming this is not treated, this will resolve on its own, but the infection doesn't go away. So these ulcers will go away, they will heal. And, about 6 to 8 weeks later, there will be secondary syphilis. So this is essentially a little more severe. So there will be, because the bacteria will grow everywhere in the body. So some of the manifestations that come up next include fever, headache, and rash. Especially when you see specific circular rash, small rashes on the flank, shoulders, arm, chest, or back, and typically on the palms of the hands or soles of the feet. And then after the secondary syphilis is resolved, assuming again no treatment, then the infection goes into a latent phase. And this is, pretty, it can be pretty long in some patients. So anywhere between, a few years to many years. And the latent, so typically we say the early latent is within the first year, and then late latent is anything more than a year. And after the latency is over, at some point it will develop into tertiary syphilis, and this is where you get the very severe complications. So typically involving the heart, so it can cause cardiovascular disease, but also neurologic conditions. And neurosyphilis specifically, which typically occurs as tertiary syphilis, it can really happen at any time. So even someone who has primary syphilis, it's not as common, but someone with primary syphilis can develop neurosyphilis pretty quickly. And neurosyphilis can damage the brain. So this is something that needs to be treated seriously. And here's a picture that essentially shows you what I described. So once somebody has infection, they will develop primary syphilis, and that takes about 2 to 6 weeks to develop after infection. So those are the local symptoms. Now, at any time, this can make its way into the CNS and cause syphilis. Neurosyphilis. With primary, typically it goes to secondary. For some patients, this actually may go to latency instead of developing those rash. So not everybody will have this secondary syphilis infection. So for that reason, it's easy for people to miss, because the primary syphilis, these lesions are painless, so people may miss it. And then if it goes straight to early latent, later on, it will go unnoticed to develop tertiary syphilis, which is, severe complications. And that's one of the reasons that the rates of syphilis are increasing significantly in recent time.